Ever since the best and brightest minds at 5 major pharmaceutical companies created vaccinations to reduce the spread of coronavirus in America. Misconceptions and rumors have hampered the progress of vaccination efforts here in Ocean County and nationwide to reliably contain the virus. As a result, we exist in an uncertain netherworld of face masks, suspicion, in which the virus remains an unseen culprit, sneezes, potential threats, and interaction often hinges on personal space requirements. The Ocean County Library and Ocean County Health Department are combining their resources to dispel the most prevalent myths about vaccines and boosters designed to quell the spread of COVID-19. And here to address them is Patricia High, the Ocean County Health Department's Assistant Health Coordinator. Thanks for coming in today, Patricia.
Yes, Tom, thank you for having me.
Okay, so let's get to the major ones. First, I already had COVID-19. Therefore, my immunity is quite adequate. I have no need of vaccine.
Right. So this is one that we actually hear quite frequently. A lot of individuals tend to rely on natural immunity to different diseases. We see that with a number of childhood illnesses that people have had growing up, and they naturally apply it to COVID-19 as well. However, what we've seen, and we see it all the more with the Delta variant these days, is that COVID is consistently changing. So we don't know with confidence or from the research the level of protection that's provided from previous infection. So as of today, the CDC is recommending that individuals, regardless of past infection, continue to get vaccinated for COVID-19 in order to either boost the immunity that they may already have or to ensure that there is the most significant, strongest protection possible for them.
How about there's no guarantee that a vaccination will prevent COVID-19, so there's really no point?
That's a great question, Tom. So one of the things that we hear a lot is that you can still transmit COVID as an individual that has been vaccinated. There is truth to that. However, what we see is that COVID-19 vaccination acts to reduce the potential for viral load within an individual's body. So that if you are infected with COVID, having the presence of the vaccination inside already allows your body the ability to more rapidly respond to that infection, to reduce the total virus circulating in your body, and ultimately works to reduce the risk of your ability to transmit COVID from one person to another. So basically what that means is that while transmission may exist, the risk of transmission is significantly less. The risk of severe illness is significantly less. The risk of death is significantly less. And altogether, there is strong evidence that shows that vaccination does a very good job of protecting each other or protecting different individuals from obtaining COVID from each other.
Patricia, how about the concept that COVID-19 is dangerous only if someone is of an advanced age or medically vulnerable already? How does that work?
Sure. So when we look at the data, we are always looking at what we call the demographics or the type of people that are being impacted by COVID to see whether or not the efforts that we are taking are best suited for the risk. And that's part of what epidemiologists do. It's part of what your local health department here in Ocean County also does. So while we see that our seniors have been at risk and some of our underserved populations, some individuals with underlying medical conditions have had greater severity of illness, it does not mean that there has been less incidence of illness among those populations. And I say that for this reason. One, there's no guarantee how an individual's immune system is going to respond to a COVID-19 infection. What that means is that, how I get COVID or how somebody else gets COVID, regardless of our health, is still subject to the person's own body and may respond differently than you expect. So we never want to make a decision based on a hopefulness that it won't be as severe for us. The other thing to consider are the people in your life. So while you yourself may not necessarily be at the same risk as individuals that may be much older or have significant underlying conditions, the truth is you may be around people that do have those conditions, or others that also have those conditions, or relationships with those that do. And that risk becomes more than just yourself. So I think when we look at it, it's very important to us that we look at not just ourselves, but we look at our sort of global community and those around us and the risk that we place to others as well.
Now let's take it out of the medical arena a little bit, because there are a lot of people who are convinced that the vaccine contains some sort of a tracing agent, even a microchip perhaps, that can monitor people's movements, and it's really a government issue.
Right. So this one is a unique one, and is one that we've heard as well. So I think a lot of this actually started, believe it or not, over a comment that Bill Gates made quite some time ago regarding digital certificates of vaccination. So Bill Gates, as a significant supporter of vaccinations and vaccine access the world around, was answering a question related to how can we ensure vaccination efforts or COVID testing efforts or COVID infection understanding in very low resource areas of the world. So he began to talk about this digital certificate, which for all intents and purposes is a small dye-based tattoo, something called quantum dot dye. So that quantum dot dye was basically a small microneedle system that would be used to place infrared ink into the arms of individuals that would either respond and react if COVID infection had been present or if the COVID vaccine had been provided. This was intended to basically create medical records where medical records didn't exist. So all of that said, that technology, one, is not being implemented. Two, calling it technology is unique because it really is basically a dye that would have been proposed to be utilized to identify an individual that was vaccinated in a low resource country. And then finally, it never had anything to do with a nanotechnology or with a microchip. There is no tracing. There is no technology being inserted into the arms of individuals. Here in the United States, we currently are not using microneedles. It's very evident to see the needle you're receiving, and it's very routine vaccine administration technology and practices. These are normal syringes, normal needles that are providing vaccine. We have access to vaccine records that allow us to not have that same need as some low-income, low-resource countries have.
Patricia, back in March of 2020, when things changed rapidly, and we started hearing about the development of a serum, and all of the companies involved were kind of almost in a race to get this done.
Right.
It seemed like it was an awful lot going on quickly, but a little bit further examination is coming to the understanding that the development of messenger RNA vaccinations actually predated the pandemic. Can you tell us a little bit about that?
Sure, I will do my best. So when we think of vaccinations, mRNA or messenger RNA vaccinations are not something that are as familiar or common to us here in the United States based on how we traditionally develop vaccines. Now, that said, many of you may know with flu vaccines or other vaccines that there can be components in the process of the vaccination development method that prevents some individuals from being able to receive vaccines, otherwise known as adverse events, medical contraindications. So, two things that were considered as we evaluated COVID-19 vaccines and the race or the desire to develop vaccines quickly. One was that we wanted vaccines to be as available as possible to as many as possible. We wanted to address some of those medical contraindication concerns. The second is that we needed to develop a vaccine quickly, and vaccine development sometimes takes a longer period of time. Fortunately for us, some of the technology for messenger RNA vaccines, as well as other treatments like cancer treatments, were already in existence. And the idea behind messenger RNA builds on the natural process of the human body. Our messenger RNA is basically that part of our immune system that communicates what's needed to occur in the development of proteins. So basically our messenger RNA comes and it tells our body, hey, listen, I need you to go ahead and make this so that we can fight this infection or we can otherwise respond to what our body's experiencing. So with messenger RNA vaccine development for COVID-19, they identified that mRNA technology that had been already researched sometimes upwards of decades for things like flu, Zika, Ebola, other viruses, as well as cancer treatments, may be very appropriate for a COVID-19 vaccine administration as well, and can work within the body's messenger RNA and existing immune system to be able to begin to develop an enhanced response. And that's exactly what we saw. We saw messenger RNA being able to prepare and ready our own body's immune system by identifying the spike protein on the outside of a COVID cell very early on. Instead of having to fight that fight when we are naturally infected, the vaccine aims to prime or charge your body to be ready to fight in advance, so that when it sees it again, it's much more successful, much faster, and allows that lower level of infection, no infection, or very mild infection to occur.
Let's discuss expectant mothers for a minute.
Okay.
Is there any reason to think that it would be better not to have the vaccine with regard to the potential effect on the fetus?
Sure. So with expectant mothers, we look at pregnant women, breastfeeding women, and infants very closely. Obviously, a very highly protected population that we want to serve. So the CDC has done research from the beginning to determine who is at greater risk. The pregnant mother that could be exposed to COVID-19 infection in the absence of vaccination, or the pregnant mother being vaccinated with a COVID vaccine. And as the CDC began to review the data that was available to them over time, the CDC has come to the decision, along with other major medical providers around the globe, including the Royal College of Obstetricians and Gynecologists, which is very comparable to our own American College of Gynecologists, to say that it is recommended that pregnant mothers and breastfeeding mothers receive the COVID vaccine in order to protect them and their unborn child from the side effects of COVID or any additional consequences from the infection itself.
What's the status of booster vaccines? What determines eligibility at this point, and is there a timeline to broaden that?
Yeah, so booster vaccines, there was a lot of excitement and a lot of anticipation for booster vaccines to come out. So early on, there was the opportunity for third dose vaccines. Third dose vaccines are a little bit different. They're the opportunity for individuals with certain medical conditions and underlying health problems to be able to get a third dose of vaccine approximately a month after their second dose, in order to create a more robust response to that vaccination. Then for the rest of the population, there is this concept of booster doses. Initially, the FDA and then ultimately the CDC's recommendation was for booster doses to be provided to older adults age 65 and older, and those with certain types of medical conditions. Here recently, I believe even just this week, the United States government has made booster doses available to the entire American public that qualify for receipt of a vaccine to begin with. So anybody basically over, or anybody indicated, for vaccination for COVID would now have access to a booster dose as well.
Can you give us a little insight about the age restrictions? In the beginning, nobody under a certain age could have. And even with the booster, it started out being recommended for people over a certain age. What are the factors that go into determining?
Absolutely. So we're always really looking at the immune status and the ability of a person to respond to either the infection or the vaccine itself. So when we looked at early recommendations for vaccination, it is rare that children or pregnant women would ever be offered a vaccine in the first stages of its initial release. The reason for that is, again, they are a population that we want to protect and that may respond differently than adults with strong immune systems. So the vaccine was initially rolled out to adults over the age of 18. The priority would have been for older adults because the concern was, and the data supported, that older adults were at greatest risk for severe complications, morbidity or mortality, meaning hospitalizations or death because of a COVID infection. So our priority was on reaching those at greatest risk from the consequences of COVID first. Then as the studies were held and additional clinical trials were assessed and the data was evaluated, we began to identify and realize that the FDA and the CDC could look and review about whether or not there was enough data to support safety and efficacy or effectiveness of vaccines in younger populations. So the Pfizer vaccine was the first vaccine that was then available for individuals also aged 12 to 17. From the results of the Pfizer trials and studies then thereafter, and the safety seen there, that was likewise followed by the Moderna vaccine. Similar, they then extended that next age group down to 5 to 11. Again, I think there the balance will always be between the risk of infection and its consequences and the risk of vaccination. So with the children aged 5 to 11, they were seeing that transmission rates were occurring quite rapidly there in school-aged children. Safety and efficacy data, effectiveness data, supported that children receiving the vaccine were benefiting from the reduced transmission, and it was further approved.
I'd like to remind you that there is a wealth of valid information about the coronavirus and about the vaccines, and it's all literally at your fingertips. Visit ochd.org for facts and for a continually updated list of vaccination centers and schedules. Visit theoceancountylibrary.org for links to clinics statewide, registration details, and answers to the most frequent questions. Thank you, Patricia, for joining us.
Thank you, Tom, for having me.
Thank you for joining us. Stay safe and stay healthy.
Support public libraries. Like, share, and subscribe for more great videos.